Hello, my name is Jewel Scott, and I'm a primary care nurse practitioner and an assistant professor at the University of South Carolina College of Nursing. I'm excited to spend a few minutes with you today to introduce you to the scientific statement on cardiovascular health and the transition from adolescence to emerging adulthood. I am joined by the vice chair of the statement.
Hi, I'm Anandita Agarwala Kulkarni, Medical Director of Preventive Cardiology and Cardio-Obstetrics at Baylor Scott & White, the Heart Hospital, Baylor Plano. It was really a pleasure to vice chair this statement with you. I want to go back to some of our initial discussions about the statement, particularly when we were thinking about how this would come together, and I was hoping that you might share with us what your original vision was and how that's played out.
This idea for the statement really came out of a lot of conversations that we were having with the Prevention Science Committee, talking about the increasing trend in major cardiovascular events occurring at younger and younger ages. And we wanted an opportunity to talk about targeted prevention in childhood and adolescence, but really thinking about what happens when young people are entering adulthood. And so when we think about cardiovascular disease, young adulthood begins at age 18, and it can go all the way up to 40s and 50s. And we know that the needs, the risk factors are really different for someone who's age 18 or 20 versus someone who's 45 or 55. And so in this emerging adulthood period, we think about ages 18 to 25, and this is a time of a lot of change. People are transitioning to independence, they're transitioning to a career, maybe even transitioning to parenting. And so it really is a critical time period in life. And there's an opportunity. We know that the prefrontal cortex begins to mature at this age, and people are able to really do a lot more extensive planning and thinking ahead. And so we have an opportunity to really promote cardiovascular health during emerging adulthood. And so thinking about the vision for this statement, we really wanted to briefly highlight what we know about life's essential 8 in emerging adulthood, but we wanted to really hone in on the contextual factors, things that we have to consider when we are developing interventions and thinking about how we engage people at this young stage of life to think about their cardiovascular health. And I know in your role as a prevention cardiologist, this is something that you think about quite a bit also.
The interesting thing about this statement is it focuses on our emerging adults, as you said, and places that into the context of the Life's Essential 8 and also utilizes risk stratification tools such as the ASCVD risk calculator and the new PREVENT equation that looks at 10 and 30-year risk. One of the most important things is, especially when we go through a transition in life, is that loss of healthcare and connection with the healthcare system. So a lot of our young folks are less likely to engage in getting good healthcare, and they're sort of lost to follow-up for a prolonged period of time. And this is a time period that really needs more innovative strategies to connect our young adults and emerging adults to healthcare. And so we talk about leveraging community health centers, college health services, as well as corporations and industries that employ a lot of these young adults to bring them back and engage them further into receiving appropriate health care. And as our emerging adults learn more about the risk factors for heart disease, they're more likely to implement healthy behaviors into their lifestyle.
I'm glad you really highlight the tools, because it was really important to talk about tools that are readily available, that people can access, that clinicians can use in their day-to-day experiences as they are seeing patients. But we also talk a lot about prevention, because at this age, as an emerging adult, that's really what we're thinking about. Our figure 2 in the statement highlights strategies for for cardiovascular health promotion and disease prevention, really across the whole prevention continuum. I think thinking about primordial prevention, it really focuses on avoiding the development of cardiovascular disease risk factors. And so when we think about primordial prevention, it's oftentimes policy change, right? Population level interventions, things about like thinking about restricting the sale of tobacco around high schools and college campuses or even limiting flavored tobacco. Like, why do we have tobacco that's flavored to taste like bubble gum and strawberries? We don't need that. And so thinking about these policy changes that could really be monumental. We highlight this term, the commercial determinants of health, which really thinks about how industry plays a role in cardiovascular health promotion.
This is a really important point. Commercial determinants of health play a huge role in our social behaviors. Where we place healthy foods on the shelf, how we market processed and ultra-processed foods, as well as sugary beverages, really impacts cardiovascular health. Also, what's important is how we deliver nutritious foods to rural communities and under-resourced communities. One of the other things that we talked about is the social determinants of health, and I know this was something really important in our discussion, how where you grow up, where you work, where you live really impacts your cardiovascular health, and I know this was something that we felt was very important to touch on.
Absolutely. I really appreciate a lot of the conversations we had about thinking about what we wanted to highlight and thinking about these social factors, which we really conceptualize as population level risk factors. And we use the Centers for Disease Control framework to talk about the 5 domains of social determinants of health. And so I think a couple of key takeaways that are highlighted in Figure 1, you mentioned earlier, healthcare access and quality. That green bubble in Figure 1, we discussed the role of having health insurance at all stages in the life course, but especially emerging adults. We know that for emerging adults, they make up the largest population of uninsured adults in the United States. There's roughly 4 million emerging adults that don't have health insurance. And so it's difficult to access the healthcare system, to have preventive care. Instead, people show up when something's wrong, but we don't get a chance to do that prevention piece, which is so important. And so I think the healthcare access and quality was really important for us to mention. Another key takeaway is thinking about that these social risk factors, these social determinants, they account for up to 40% of health outcomes, but we know that they don't impact all populations equally. And I think that was also really important for us to bring that out in this statement, to talk about that. Because of systemic inequities, we know that some racial and ethnic groups are more likely to live in under-resourced neighborhoods. And we know a lot about the neighborhood and the built environment, having access to green spaces, the role of air pollution and noise pollution, and how that intersects also with cardiovascular health. If I was going to highlight another social determinant of health, it would really be the social and community context. And I think that's in the lavender bubble on that Figure 1. Recently, the Surgeon General released a report talking about the epidemic of loneliness. Over 50% of adults in the US report being lonely, but it really clusters at 2 ends of the age range. We see it in older adults, but also in younger adults, especially emerging adults. There's a really strong body of literature on social isolation and the impact it has on cardiovascular outcomes, but most of that literature is all focused on older adults. There's a huge gap in knowing how social isolation in emerging adults, young adults, impacts their current and their future cardiovascular health. And so I think that is so important that we think about as research priorities and think about opportunities for interventions for this age group. We have to think about social connections, and when we think about social connections in emerging adults, we think about social media, right?
Yeah.
Like it comes to mind, and I saw some Pew research recently that shows that most emerging adults report that they're constantly on the internet, they're constantly on social media, and we haven't yet to figure out how to leverage social media, how to harness that for cardiovascular health promotion, for disease prevention, to build social connections in a healthy way.
Absolutely. I think it's so important that we think about mental health, social isolation, and how people interact with digital media. What's really important here is that we encourage our transitioning adults to learn about their cardiovascular risk factors, because we know risk factors for heart disease start early in life. And if we catch these patients early and risk stratify them early, we have the opportunity to not only prevent heart disease, but optimize cardiovascular health.
Absolutely. Our last figure, Figure 3, does a really nice job of kind of summarizing everything. We summarize some of the evidence, we talk about future research directions and clinical opportunities, but also right in the center of that figure, we talk about populations that we really have to think about that we know have exceptionally high risk for cardiovascular disease, and that should be considered priority populations, I think, for emerging adults as we think about clinical interventions as well as population level interventions, populations such as youth who are aging out of the foster care system, for example, that we don't have great interventions, and there's many opportunities for us to do some good work in this area. So, with that, I really want to thank the writing committee. We had a fantastic writing committee that was really interdisciplinary. We had representation from nurses, from physicians, from dietitians, from psychologists, and we really came together to work really hard on this statement. So I want to thank the writing committee as well as the American Heart Association, and really encourage people to take the time to read the paper and consider how you can apply it to the work that you're doing. So on behalf of the writing committee, I want to say thank you so much for listening, and we look forward to engaging at another time.
you.